Welcome to the IAC Nuclear PET Accreditation On-Demand webcast on protocols. I'm Mary Beth Farrell, the Director of Nuclear PET Accreditation, and in this webcast I will be discussing the multiple protocol requirements for accreditation. I will first review the general requirements for protocols. Then I will specifically discuss the requirements for clinical imaging protocols, exercise and pharmacologic stress testing protocols, the specific requirements for equipment quality control, and then I'll finish up by discussing some of the miscellaneous protocols, such as the patient identification or the radiation safety protocols required for application submission. I will focus on the requirements and standards for each area and discuss some of the common problems encountered by facilities. I will also mention any resources available to help facilities in writing their protocols. I'd like to point out that laboratories are required to have protocols and policies for nearly every aspect of facility operation. Not all of the protocols are required to be uploaded as part of the application process, but they may be evaluated at the time of site visit. So let's start with the definition of a protocol. A protocol is a detailed plan of a scientific or medical experiment, treatment, or procedure. Protocols detail exactly how a test should be performed and are critical in standardizing operations in a facility. There are specific elements or sections that must be included in any protocol. The IAC Nuclear PET Standards and Guidelines are the most important document, and you must be familiar with standards prior to writing or updating any protocol. The standards identify what protocols must be in place and exactly what must be included in those protocols. The standards are divided into three parts, A, B, and C. The requirements for the various types of protocols are found in different parts of the standards. Part A of the standards deals with the organizational aspects of a facility. In Section 4 of Part A, you'll find the requirements for patient and facility safety, such as the patient identification, pregnancy and breastfeeding policies, and I'll review these at the end of this webcast. Other administrative policies, such as the request for services, informed consent, infection control, hazardous material, or medical emergencies, are also found in Section 4A. The radiation safety protocols are found in Section 4A also. Part B of the standards deals with the examinations and procedures. Standard 1.2b contains the requirements for imaging and non-imaging equipment quality control protocols. Section 2b discusses the requirements for clinical imaging, stress, and therapy protocols. To be in compliance with the standards, protocols must be detailed, laboratory-specific, and accurately describe the details of all procedures, and contain all required elements. When writing your lab protocols, keep this in mind. Your protocols should be so detailed and specific that any technologist could walk into your facility and perform a study exactly the same way you do. Consistency in how imaging studies are performed is very important, considering that patients often have serial studies, such as when patients have PET scans to detect tumor reoccurrence. If a patient had a study last year and a follow-up study this year, differences in the results should be due to changes in their clinical scenario and not as a result of changes in the technical performance or quality of the study. A common error that laboratories make when applying for accreditation is to submit a copy of the equipment manufacturer's manual in lieu of a protocol. A manufacturer's manual is not lab-specific and does not define exactly how the lab performs the exam or for what reasons. Keep these general rules in mind regarding protocols. Procedure manuals must be compiled into one notebook or area, and they must be organized for easy use, having a table of contents. Applicable sections or headings for the table of contents could include clinical imaging protocols, exercise and or pharmacologic stress protocols, therapy protocols, equipment quality control, radiation safety and radioactive materials handling, administrative policies, and lab quality assessment or improvement. Availability of protocols in digital format is desirable. The protocol manual must be readily available. It can't be helpful to anyone if they can't be found. It is not uncommon during a site visit for us to find that facilities have protocols in several places and that they are unable to locate specific protocols. Protocols must be reviewed and updated by the medical director at least annually. Reviews and revisions must be dated and initialed or signed. Personnel must have read and be appropriately trained in and have competence documented to perform or comply with protocols. Documentation is typically found as initial orientation and training records. An example of a clinical competence checklist can be found on our website under the Sample Documents section. All protocols and the facility's performance must be in compliance with all applicable federal, state, and local requirements, including the Nuclear Regulatory Commission or, in agreement states, with state regulations for medical use of radioisotopes. In addition, they must be in compliance with any regulations relating to license, scope of practice, facility operations, and billing requirements. Finally, all protocols must be in compliance with accepted practices such as those published in professional guidelines, such as those by the American Society of Nuclear Cardiology or the Society of Nuclear Medicine and Molecular Imaging. A list of guidelines and references is published at the end of the standards in the bibliography section. This list can also be found on our website. If you are not familiar with the guidelines published by the American Society of Nuclear Cardiology or the Society of Nuclear and Molecular Imaging, it is vital that you download copies and familiarize yourself with them. They are essentially best practice for nuclear medicine and PET exams. Another particularly useful document is the Guide for Diagnostic Nuclear Medicine written by Dr. Jeffrey Siegel and published by the Society of Nuclear Medicine and Molecular Imaging. It is a manual explaining the pertinent NRC regulations, and it provides suggested procedures for compliance. It is essentially the NRC for dummies and contains many sample radiation safety policies. Let's now move on and discuss the requirements for imaging protocols. There must be written protocols for every clinical procedure performed at the facility, even those performed only occasionally. The requirements for clinical imaging protocols are listed in Standard 2.3.1b. I'll address each of these requirements separately. First, every protocol must have indications and contraindications, reasons why you would or would not perform the test. If there are no contraindications for performing the test, this should be stated. The protocol must list patient preparation and education instructions such as food and diet restrictions, if any, withholding or non-withholding of medications or other relevant information. For instance, for adenosine stress myocardial perfusion imaging, the patient must avoid caffeine for 12 to 24 hours, and theophylline medication should be withheld for 24 to 48 hours. Other patient instructions may include skin preparation, wound care, changing or removal of dressings or casts for general nuclear medicine, and blood glucose levels for PET scanning. If there are no patient preparations or restrictions, the protocols must specifically state this. The protocol must state the radiopharmaceutical identity, dose, and route of administration. Technically speaking, if this is not specifically stated in the protocol, then each patient is required to have an individual written prescription. Therefore, it is important that these things be listed in the protocol. Identity means both the isotope and the radiopharmaceutical, such as technetium-99m cestamide. Dose may be listed as a range, and route of administration is things such as intravenous, intramuscular, subcutaneous, ingestion, inhalation, etc. All non-radioactive drugs used in the procedure must also be stated in the protocol, including dosage, timing or when it is given, route of administration, patient instructions, patient monitoring, and any other precautions or restrictions. Examples include pharmacologic stress agents such as adenosine, regadenoson, dipridamol, and dobutamine, and drugs used in general nuclear medicine imaging such as syncolide, cholecystokinin, morphine sulfate, Lasix, captopril, pentagastrin, Diamox, lisinopril, etc. A common non-radioactive drug often missing in equilibrium radionuclide or MUGA protocols and GI bleed protocols is pyrophosphate. The camera setup such as collimator, energy window setting, orbit and orbit type, gating, matrix size, zoom, or acquisition types such as static, dynamic, planar, SPECT, or PET-CT must be stated. The patient position, such as supine, prone, upright, posterior, anterior, head in, head out, arms up, arms down, or neck extended, such as in thyroid imaging, must be stated. The camera position, such as the starting angle, detector configuration, such as 90 degrees or 180 degrees, caudal tilt, or detector to patient distance must be stated. The camera computer-specific acquisition instructions, including the views, timing of the views, time per counts per view, or number of views, as well as PET-specific parameters, pre-filtering or reconstruction, and if applicable, attenuation correction must be stated. These parameters must be in adherence to the American Society of Nuclear Cardiology or the Society of Nuclear Medicine and Molecular Imaging's published guidelines. Camera computer-specific processing protocols, including instructions such as filtering, reconstruction parameters, reconstruction algorithms, attenuation correction, motion correction, curve generation, region of interest placement, reformatting or reorientation, and quantitative analysis requirements must be listed. And finally, camera computer-specific instructions regarding the images and data to be displayed for physician interpretation must be listed. This includes PACS instructions. Instructions for how the image will be labeled must be stated and include facility name, patient name, date of birth, patient identifier, date of the study, time interval, view or projection, laterality, and anatomic markers. We realize that most technologists are not English or journalism majors and that writing a protocol can seem intimidating. Therefore, there are numerous sample protocols listed on our website to help you get started. But remember, the protocols must be customized to reflect actual equipment and practices followed in your laboratory. These documents are only samples from other laboratories and are not intended to represent what you must or should do in your own facility. Several of the common clinical protocol mistakes that facilities applying for accreditation make is, 1, submitting protocols that are not detailed and camera-specific. We've seen protocols that list cameras that are not even used in a laboratory. Many protocols are not detailed to the level I just discussed. As I stated before, your protocols must be specifically detailed to enable recreation of the procedure. Our application reviewers will evaluate your protocol with this in mind. And frequently, protocols are missing processing instructions. Let's now discuss the protocol requirements for both exercise and pharmacologic stress testing. There are essentially 6 elements which are listed in Standard 2.4.2b that must be included in all exercise and pharmacologic stress protocols. These include the graded exercise protocol or infusion protocol, the timing of assessments during the stress activity, the injection criteria and stressing endpoints, reasons for early termination, post-stress monitoring, and adverse effects. Let's look at each of these elements separately. The exercise stress procedures must state the exercise protocols used and include charts showing the speed and incline of the treadmill and workload. The protocol should give directions on when a different exercise protocol may be used. For instance, your facility may be using a Bruce protocol for patients in relatively good shape, and it might use a Naughton or a modified Naughton protocol for elderly patients or patients with poor functional capacity. The reasons for using a specific protocol should be stated. Pharmacologic stress protocols must have the prescribed dose and infusion charts for the pharmacologic agents such as adenosine, dipridamole, or dobutamine. Your protocol must specifically state the time of measurement of the symptoms, heart rate, blood pressure, and ECG tracing. For example, are ECG tracings recorded every minute or only once a stage? When is the blood pressure specifically taken? At 2 minutes into every stage? The protocol must list the injection criteria and exercise or testing endpoints, including any specific events that are reasons for stopping the stressing activity, such as duration of the pharmaceutical administration or specific symptoms of peak exercise. These protocols must specifically state when the tracer is injected either by time or other criteria relative to the stress type, such as the tracer is administered at 2 minutes into a 4-minute adenosine protocol. It should be noted that, in general, exercise stress tests should be symptom-limited unless indications for stopping the test are achieved early. Symptom-limited means that the patient is too fatigued to continue or the patient has moderate shortness of breath and unable to continue. Achievement of 85% of the maximum predicted heart rate is not a sufficient an indication for termination of the test. Stress tests must be symptom-limited along with reaching the predicted heart rate. Your protocol and report should clearly state this in order for your facility to be granted accreditation. Continuing, the exercise and pharmacologic stress protocols must state the reasons for early termination of the stress test, such as ST segment depression greater than 2 millimeters, ST segment elevation, near syncope, or ventricular tachycardia. For pharmacologic stress, examples of reasons for early termination or reversal of the drug could include severe hypertension or hypotension or development of a second or third degree heart block. Similar to monitoring during the stress test, your protocol must also have instructions for post-stress monitoring to include the time of measurement of symptoms, heart rate, blood pressure, and ECG tracings, and it must also have instructions for terminating the recovery period. For example, does your facility terminate the recovery period after 5, 10 minutes, or when the patient returns to pre-test stressing levels? How often do you obtain a blood pressure or an ECG? And finally, the protocols must have instructions for the identification and treatment of common adverse effects of both exercise and pharmacologic stress. Most facilities have instructions to administer aminophylline to treat side effects of dipyridamole or adenosine, but they fail to list instructions for other adverse effects of exercise, such as hypertension, dyspnea, and chest pain. This slide demonstrates some of the common adverse effects of exercise stress testing and treatment. Reminder, not every adverse effect of exercise requires a code or breaking into the crash cart. By identifying and treating adverse effects appropriately, a more serious situation may often be avoided. Several of the common exercise or pharmacologic stress protocol mistakes made by facilities applying for accreditation include submission of protocols that do not include the timing of assessments during both stress and recovery. Remember, the timing for obtaining heart rates, blood pressure, ECG tracings, and symptoms must all be specifically stated. Many submitted protocols do not include instructions for both identification and treatment of adverse effects of both exercise and pharmacologic stress. And frequently, protocols do not indicate that symptom-limited stress testing is performed. Make sure your protocol does not mislead or indicate that exercise is terminated when 85% of the maximum heart rate is achieved. And remember, there are sample protocols on our website that may be downloaded and customized to help you when writing your protocol. Currently, there are protocols for exercise stress, adenosine, regadenoson, dipyridamole, and abutamine stress. So let's now move on to discuss the protocol requirements for equipment quality control. There must be written protocols for quality control for gamma cameras, PET scanners, PET CT or SPECT CT equipment, non-imaging equipment such as survey meters, dose calibrators, well counters, interoperative probes, and uptake probes. And there must be protocols for other equipment such as emergency equipment, the glucometer, the xenon trap, or infusion pump. Note, the quality control protocols must be reviewed and updated as equipment is changed and at least every 3 years by the medical director, medical physicist, or other responsible person. Again, the protocols must be site-specific and camera-specific, and they must be step-by-step. The quality control protocols must include frequency of test performance. Is the test done daily, weekly, monthly, or quarterly? Type and location of source, if applicable. Is a sheet source or a fillable source used? Equipment set up to include things such as whether it is an intrinsic or extrinsic test, the collimator, energy and window settings, matrix size, zoom, acquisition instructions, including the views and time per count, processing instructions, such as, if applicable, such as region of interest placement for quantification of sinogram generation or graphs, evaluation and acceptable range or tolerance limits of the results of each procedure. For instance, what is the acceptable pixel deviation for a center of rotation set? What is the cutoff level for an intrinsic uniformity? Instructions for corrective action for an out-of-tolerance result. If the numbers are off, do you reboot the system, perform a correction, call the service engineer? And finally, the protocols must contain instructions for record documentation and retention and for comparison with previous results. For example, the protocol must state how long the resolution or bar phantom images must be kept and how they should be compared to the previous bar phantom results. The results of quality control tests must be reviewed by appropriate staff in a timely manner and action taken if the results are not within tolerance limits. For each quality test performed, the following information should be recorded either on paper or in the laboratory management program and include the test performed, the date and time of the test, identification of the device tested, the make, model, or serial number of any reference sources used, if applicable, the results of the test, a notation indicating if the test result was or was not acceptable, and the signature or initials of the individual performing the test or clear delineation of this duty written into the policy. The most common mistakes made by laboratories regarding the equipment quality control protocols are that they fail to submit the required or requested protocols. Labs frequently do not have protocols for their non-imaging equipment, such as for the dose calibrator, linearity, or accuracy. Laboratories sometimes submit the manufacturer manual for the equipment rather than the site-specific policy. And protocols for equipment often do not contain trigger levels or actions for unacceptable results or instructions for record retention in comparison with previous results. Here's a little test. Is the flood shown above acceptable? Can patients be imaged using the equipment used to obtain this flood? Well, that's a trick question. It all depends on the tolerance levels designated in the protocol. Based on the action levels listed above, the flood should be repeated once, and if the result is the same, the physicist and/or supervisor must be notified, and a recalibration of the equipment is necessary. I'll now finish up by reviewing a few of the other miscellaneous protocols that must be submitted as part of the application process. There are 3 important protocols that all labs must submit as part of the application. Labs must submit their patient identification policy, their pregnancy or breastfeeding screening protocol, and the administration of radiopharmaceuticals to patients protocol. As I just mentioned, these protocols are very important, and it behooves labs to pay attention to the requirements for these protocols listed in the standards and make sure their protocols are in compliance. For example, Standard 4.1.1.1a regarding patient identification states that the protocol must indicate that 2 independent patient-specific identifiers must be used. This may be accomplished by examination and comparison of the patient's identification bracelet, hospital identification card, driver's license, or by asking the patient to state his or her full name and birth date. It is best to avoid procedures in which the patient can answer yes or no. The most common mistakes relevant to the miscellaneous protocols is that they are missing one of the specific requirements listed in the standards. In particular, facilities submit incomplete protocols for the administration of radiopharmaceuticals to patients about 15% to 20% of the time. There are examples of all these protocols listed on our website, and facilities are encouraged to customize them to meet the practices performed in their laboratory. In summary, I've reviewed the general protocol requirements and the specific requirements for imaging, stress, quality control, and miscellaneous protocols. Remember when writing your protocols to pay attention to the specific protocol requirements listed in the standards. Make sure your protocols are site-specific and reflect the actual practices performed in your facility. Make sure your protocols are sufficiently detailed to enable recreation of the protocol. And don't forget that there are numerous sample protocols listed on our website that can be customized to reflect the practices in your own facility. The IAC strives to assist facilities in the most complete application submission possible. A series of other webcasts, articles, checklists, and sample documents are posted on the IAC Nuclear PET website in order to provide additional guidance to those seeking accreditation. Please feel free to contact me or any of the other IAC Nuclear PET staff at any time with questions. We look forward to helping you.